6 months ago, I was told I needed cataract surgery within the year. My ophthalmologist measured a grade 2 plus nuclear sclerotic cataract in my left eye and early cortical opacities in my right. My corrected visual acuity had dropped to 20/40. Rather than scheduling the procedure immediately, I did what I've done for 4 decades as a researcher. I went to the literature. I spent the next 5 months reading every peer-reviewed study, every clinical trial, every preclinical report I could find on non-surgical approaches to cataracts. I tested protocols on myself. I tracked my lens density scores and contrast sensitivity at regular intervals. I am Dr. Walter Miles, and today I'm going to share everything I found. What works, what does not, what is dangerously overhyped, and what is genuinely promising. If you or someone you love has cataracts, this may be the most important 30 minutes you invest before making a decision. Let me be direct from the outset. Surgery remains the gold standard, with a success rate exceeding 90% across more than 3 million procedures annually in the United States alone. Nothing I present today changes that fundamental fact, but there are developments, real, published, measurable developments that deserve serious attention, particularly for early-stage cataracts. And there are popular claims circulating on social media that deserve equally serious scrutiny. Mechanism 1, understanding why cataracts form the crystallin collapse. Before we discuss solutions, we must understand the problem at the molecular level. A cataract is not a film growing over the eye. That is a common misconception. It is a structural failure occurring inside the crystalline lens itself. The human lens is composed primarily of crystalline proteins, alpha, beta, and gamma crystallins, arranged in an extraordinarily precise lattice. This arrangement is what makes the lens transparent. Alpha crystallins function as molecular chaperones. They bind to damaged beta and gamma crystallins and prevent them from aggregating. Think of alpha crystallins as quality control inspectors on an assembly line. As long as they are working, misfolded proteins are caught and neutralized before they can cause problems. With aging, several things happen simultaneously. First, oxidative stress depletes glutathione in the lens. Glutathione is the lens's primary antioxidant defense. Research published in the Journal of Biological Chemistry has shown that glutathione levels in the nucleus of a 60-year-old lens are roughly 1/10 of what they were at age 20. Second, glycation occurs. Glucose molecules bind to crystalline proteins, forming advanced glycation end products, or AGEs, which cross-link proteins into insoluble aggregates. Third, the alpha crystalline chaperones themselves become damaged and overwhelmed. They simply cannot keep up with the accumulating damage. The result is protein aggregation. Soluble crystallins become insoluble. Light scatters instead of passing through. The lens gradually opacifies. This process is fundamentally similar to what happens in neurodegenerative diseases like Alzheimer's. In both cases, proteins lose their native conformation, aggregate, and cause tissue dysfunction. This parallel is not coincidental. It is why some of the most promising cataract research draws on protein folding science. Understanding this mechanism is critical because it tells us exactly what any legitimate non-surgical treatment must accomplish. It must either prevent further crystalline aggregation, restore chaperone function, dissolve existing aggregates, or some combination of all three. Any proposed treatment that cannot explain how it achieves at least one of these goals at the molecular level should be viewed with considerable skepticism. Mechanism 2, the DMSO and Castor oil phenomenon, separating pharmacology from folklore. I need to address this directly because it is the question I receive most frequently. The combination of DMSO, dimethyl sulfoxide, and castor oil applied as eye drops at bedtime has become enormously popular on social media platforms. Thousands of testimonials claim partial or complete cataract reversal. I investigated this claim thoroughly. DMSO is a genuinely fascinating compound. It is a powerful solvent and penetration enhancer that disrupts lipid bilayers, creates water pores through cell membranes, and can carry dissolved substances through biological barriers. It has documented anti-inflammatory properties, scavenges hydroxyl radicals, and has legitimate FDA approval for one condition: intravesical installation for interstitial cystitis. A 2021 review by Huang and colleagues, published in the Journal of Ocular Pharmacology and Therapeutics, makes a reasonable scientific case for further investigation of DMSO in ophthalmic applications. Here is where it becomes complicated. The most extensive body of peer-reviewed literature on DMSO and the eye lens actually documents DMSO causing lens changes in animals. Rubin and Mattis reported in Science in 1966 that oral DMSO administration produced refractive index changes in dog lenses. Knoll and colleagues confirmed in Toxicology in 1975 that the lens was DMSO's primary target organ in dogs, pigs, and rabbits. The biochemical changes they documented, reduced soluble alpha-crystallin, depleted glutathione, increased insoluble protein, are precisely the pathological cascade of cataract formation. However, and this is a critical however, these animal lens changes have never been replicated in humans. Gordon and Kleiberger examined 157 eyes treated with concentrations up to 66% DMSO for up to 19 months and found zero ocular toxicity. A randomized double-blind scleroderma trial involving 84 patients treated with 70% topical DMSO found no lenticular changes. Approximately 27,000 adverse event case reports collected by pharmaceutical companies detected no eye damage. This species discrepancy, dramatic lens toxicity in dogs but apparent safety in humans, remains scientifically unexplained. On the potentially beneficial side, Huang and colleagues published a study in Vivo in January 2025 demonstrating that subconjunctival injection of 50% DMSO significantly slowed cataract progression in a diabetic rat model. This is the strongest preclinical evidence supporting a protective role. But note carefully, this was an injection, not eye drop, in rats with diabetically induced cataracts, not age-related cataracts. Conversely, Gong and colleagues tested DMSO as a chemical chaperone for mutant gamma-D crystallin in molecular vision and found it did not improve protein solubility, meaning DMSO cannot directly disaggregate the misfolded proteins that form cataracts. Now, castor oil, the evidence here is far simpler to summarize. There are 0 clinical trials, 0 animal studies, and 0 in vitro studies testing castor oil for cataracts. 0. The fundamental problem is anatomical. Cataracts form inside the crystalline lens, behind the cornea and iris. As multiple ophthalmologists have stated plainly, even with castor oil applied to the eye surface, it cannot penetrate deep enough to reach the lens. Castor oil does have legitimate evidence for surface conditions. A randomized, double-masked, placebo-controlled trial published in Ophthalmology demonstrated that 2% castor oil improved meibomian gland dysfunction and tear film stability. This likely explains many positive testimonials. People with dry eye often experience blurred vision that clears when the tear film is restored, creating a genuine perception of improved vision that has nothing to do with the lens. Additionally, Seid and colleagues published in Investigative Ophthalmology and Visual Science that castor oil is cytotoxic to human conjunctival cells, inducing cell death and increased reactive oxygen species. The single published human case report on DMSO for cataracts, Moran, 2021, in the International Journal of Complementary and Alternative Medicine, describes one individual's self-experiment using 40% DMSO combined with N-acetylcarnosine and Lanosterol, reporting improvement after 2 months. This was published in a low-impact journal with no controls, no objective imaging, and a sample size of 1. My assessment, DMSO is under-researched for ophthalmic applications, not proven effective. The combination with castor oil has no scientific basis whatsoever. Anyone considering this approach should understand they are self-experimenting with a combination that has no clinical evidence of efficacy and carries real risks, particularly DMSO's ability to transport any contaminant on the skin or in the solution directly into delicate intraocular tissues. I strongly urge extreme caution. Mechanism. 3. C-KAD, the first clinically proven non-surgical candidate. This is where the science becomes genuinely exciting. C-KAD, developed by Livianex, is a 2.6% EDTA ophthalmic solution, EDTA being ethylenediamine tetraacetic acid, a chelating agent. This is currently the most clinically advanced non-surgical cataract treatment in the world. The mechanism is elegant. Cataracts contain accumulations of iron and calcium ions that bind to aggregated proteins and contribute to light scattering. EDTA chelates, binds and removes these metal ions, potentially destabilizing the protein aggregates and restoring lens transparency. Think of it as removing the scaffolding that holds the cloudy protein clumps together. A phase 1-2 placebo-controlled randomized clinical trial was published in the American Journal of Ophthalmology in August 2024. In a subgroup analysis of 41 eyes with early-stage cataracts, 66.7% of treated eyes versus 35.0% of placebo eyes achieved clinically significant contrast sensitivity improvement at 120 days. The treatment group also showed measurable reduction in lens density on objective imaging. At the American Academy of Ophthalmology meeting in October 2024, Livianex reported a positive end-of-phase 2 meeting with the FDA, meaning the agency agreed on phase 3 trial design. If phase 3 succeeds, this could become the first FDA-approved non-surgical cataract treatment. I want to be measured in my enthusiasm. Phase 2 data is encouraging but not conclusive. The subgroup showing benefit had early to moderate cataracts. This may not work for advanced cataracts. Phase 3 trials take years, but this represents the highest quality of evidence for any non-surgical approach, and I am monitoring it closely. Mechanism. 4. Lanosterol and oxysterols, the rise and partial fall of a Nature paper. In 2015, Zhao and colleagues published a landmark study in Nature showing that Lanosterol, a naturally occurring sterol in the lens, could reverse cataracts in dogs when applied as eye drops. The excitement was enormous. The paper demonstrated that Lanosterol could dissolve amyloid-like aggregates of crystallin proteins in vitro in cultured cells and in living animal lenses. The proposed mechanism was compelling. Lanosterol integrates into the hydrophobic core of crystalline aggregates, disrupting the intermolecular contacts that hold them together. It essentially acts as a molecular wedge, prying apart misfolded protein clumps and allowing individual proteins to refold into their native transparent conformations. However, the translation to human tissue has been disappointing. Multiple independent research groups attempted to replicate these findings in human cataract lens tissue and could not reproduce the dramatic results seen in dogs. A 2024 UK Biobank genetic analysis examining 45,149 cataract cases found no evidence for genetic associations between Lanosterol and cataract risk, further weakening the therapeutic hypothesis. Viewpoint Therapeutics developed VP1001, an oxysterol compound designed to overcome Lanosterol's solubility limitations. Preclinical data showed improvement in 61% of treated mouse lenses, but no human clinical trial has been completed for either Lanosterol or VP1001. The Lanosterol story is instructive. A beautiful mechanistic hypothesis and dramatic animal results did not translate to humans. This is exactly why I insist on clinical trial data before recommending any intervention. Biology is far more complex than any single experiment can reveal. Mechanism 5, N-acetylcarnosine, compelling theory, questionable evidence. N-acetylcarnosine, marketed as Can-C eye drops, has been promoted as a cataract treatment for over 2 decades. The compound is a prodrug. It penetrates the cornea and releases L-carnosine inside the aqueous humor, where it acts as an antioxidant and anti-glycation agent. The theoretical basis is sound. If oxidative damage and glycation drive crystalline aggregation, then an antioxidant that can reach the lens interior should help. One clinical trial published by Babajayev and colleagues reported significant improvements in lens clarity and visual acuity over 6 to 24 months. However, a 2017 Cochrane review, the gold standard of evidence synthesis, it concluded there is no convincing evidence that N-acetylcarnosine reverses cataracts. The review noted that all positive studies originated from a single research group that also holds patents on and markets the product. This is a significant conflict of interest that undermines the reliability of the findings. I experimented with N-acetylcarnosine for 12 weeks. My subjective impression was modest improvement in visual clarity, but my measured lens density scores did not change significantly. I cannot rule out placebo effect or tear film optimization as explanations. Mechanism 6, RNF114, and the ground squirrel breakthrough, the future of cataract biology. This is the research I find most scientifically exciting, though it is the farthest from clinical application. In September 2024, researchers at the National Institutes of Health published a remarkable study in the Journal of Clinical Investigation based on an unexpected observation. 13-lined ground squirrels, which hibernate at near-freezing body temperatures for months, develop severe cataracts during torpor, but then completely clear them upon arousal. The researchers identified a protein called RNF114, an E3 ubiquitin ligase, that facilitates the targeted degradation of aggregated lens proteins via the ubiquitin proteasome system. Essentially, RNF114 tags damaged crystallins for destruction by the cell's recycling machinery. When they introduced RNF114 into rat lenses with experimentally induced cataracts, the cataracts reversed. This discovery is profound because it reveals that biology has already solved the cataract problem in ground squirrels. The question is whether we can harness this mechanism in humans. A drug or gene therapy that upregulates RNF114 activity in the human lens could, in principle, reverse cataracts by clearing aggregated proteins through normal cellular degradation pathways. But this is years, likely a decade or more, from any clinical application. It is early-stage fundamental biology, not a treatment. Mechanism 7. Oxidative defense. What I do to protect my remaining lens. Transparency. While waiting for non-surgical treatments to mature, the most evidence-based approach is to slow cataract progression by addressing the upstream drivers: oxidative stress, glycation, and chronic inflammation. This is where my training in metabolic regulation becomes directly relevant. Glutathione is the lens's primary antioxidant. Its depletion with age is one of the strongest correlates of cataract progression. I focus on supporting glutathione synthesis through its precursor amino acids. I supplement with N-acetylcysteine at 600 milligrams twice daily. This provides the rate-limiting cysteine substrate for glutathione production. Research published in Nutrients demonstrates that NAC supplementation significantly raises systemic glutathione levels. Glycation is driven by elevated blood glucose. I maintain tight glycemic control through time-restricted feeding within an 8-hour window, which my continuous glucose monitor confirms reduces my average glucose from 102 to 88 milligrams per deciliter. I avoid refined carbohydrates and seed oils, both drivers of the oxidative and inflammatory milieu that accelerates crystalline damage. I supplement with lutein at 20 milligrams and zeaxanthin at 4 milligrams daily. These carotenoids concentrate in ocular tissues and filter high-energy blue light that generates reactive oxygen species in the lens. Multiple epidemiological studies, including data from the age-related eye disease study, demonstrate reduced cataract risk with higher dietary lutein and zeaxanthin intake. Vitamin C is present in the aqueous humor at concentrations 20 to 70 times higher than in plasma. The eye actively concentrates it as a protective mechanism. I ensure adequate intake through both diet and supplementation at 500 milligrams twice daily. I also prioritize adequate sleep, 7 to 8 hours, targeting 90 minutes of deep sleep. Growth hormone, which is primarily secreted during deep sleep, activates repair pathways, including proteostasis mechanisms that help clear damaged proteins. Chronic sleep deprivation elevates cortisol, which impairs these repair systems. My complete daily protocol for lens protection. Morning and upon waking, I take 600 milligrams N-acetylcysteine on an empty stomach. I practice 10 minutes of focused breathing to manage cortisol. My first meal occurs at 10 a.m. within my 8-hour eating window. With my first meal, 20 milligrams lutein and 4 milligrams zeaxanthin, taken with fat for absorption. 500 milligrams vitamin C. I prioritize foods rich in sulforaphane, broccoli sprouts, cruciferous vegetables, which activate the NRF2 pathway, the master regulator of antioxidant gene expression. Afternoon, Second dose of 600 milligrams NAC, 500 milligrams vitamin C. I maintain physical activity, a 30-minute walk after my largest meal, which blunts the glucose spike by 30 to 50% and reduces the glycation burden on all tissues, including the lens. Evening. My last meal concludes by 6 p.m. No food for a minimum of 5 hours before sleep. I use blackout curtains, keep the room at 18 degrees Celsius, and target a consistent 10 p.m. bedtime. This circadian alignment optimizes deep sleep and the growth hormone pulse that supports cellular repair. Weekly, I complete one 24-hour fast, which research shows activates autophagy and enhances proteostasis, the cellular quality control systems that clear damaged proteins. This is directly relevant to lens health. Every 90 days, and I have a comprehensive ophthalmologic exam, including lens density measurement and contrast sensitivity testing to objectively track any changes. After 5 months on this protocol, here is what I have documented. My corrected visual acuity improved from 20/40 to 20/30 in my left eye. I want to be precise about what this means, so it is a modest but real improvement, and I cannot definitively attribute it to any single intervention. My contrast sensitivity scores improved marginally. My lens density measurement on Scheimpflug imaging showed no progression. The cataract has not worsened, which in itself is a meaningful outcome, given that cataracts typically progress continuously. My fasting glucose dropped from 102 to 88 milligrams per deciliter. My HbA1c decreased from 5.6 to 5.2%, moving further from the glycation promoting range. My high sensitivity C-reactive protein, a marker of systemic inflammation, decreased from 1.8 to 0.6 milligrams per liter. Subjectively, I noticed reduced glare sensitivity, particularly when driving at night, and improved color perception. These are consistent with either modest lens improvement or adaptation, and I report them with appropriate caution. I have not canceled my surgical consultation. If my cataract progresses to the point where it significantly impairs my daily function, I will proceed with surgery. It is a well-established, safe procedure with excellent outcomes, but I have bought myself time, and the science is moving fast enough that I believe the next 3 to 5 years may bring genuine non-surgical options for early-stage disease. I have organized every approach I investigated by the quality of evidence supporting it. This is essential for making informed decisions. At the top, robust Phase 3 evidence and FDA approval, sits cataract surgery alone. Over 90% success rate across millions of procedures annually. At the next level, emerging clinical evidence from Phase 1 to 2 human trials, sits C-KAD, the EDTA chelation drops, with published placebo-controlled data showing benefit in early cataracts. Below that, preclinical evidence with strong mechanistic support, we find VP101 oxysterol, the RNF114 ubiquitin pathway, and to a lesser extent, Lanosterol, though Lanosterol has largely failed in human tissue translation. Below that, weak or conflicted evidence, sits N-acetylcarnosine, where all positive studies come from a single group with commercial interests. Below that, animal evidence only, no human data, sits DMSO alone, based on one diabetic rat study from January 2025. At the bottom, no evidence whatsoever, sits the DMSO plus Castor oil combination, supported only by anecdotal testimonials, uncontrolled self-experiments, and commercially motivated promotion. No clinical trial, no preclinical study, no published mechanistic rationale. I present this hierarchy not to dismiss anyone's personal experience. I understand the desperation that comes with progressive vision loss, but personal experience without controlled comparison is unreliable. The placebo effect is real. Tear film improvement from castor oil genuinely improves surface optics without affecting the lens. Regression to the mean occurs. These are not theoretical concerns. They are documented sources of error that clinical trials exist to control for questions I frequently encounter. Should I cancel my cataract surgery and try DMSO and castor oil first? No, I cannot state this more clearly. If your ophthalmologist recommends surgery and your cataracts are significantly impairing your daily function, delaying proven treatment for an unproven alternative puts your vision at risk. Cataracts progress, and advanced cataracts are harder to treat surgically. I investigated alternatives because my cataracts were early stage, and I was willing to accept the risk of gradual progression while monitoring closely. That calculation changes entirely for moderate to advanced disease. Is cataract surgery safe? Modern cataract surgery, phacoemulsification with intraocular lens implantation, is one of the safest and most commonly performed surgeries in medicine. The procedure takes approximately 15 minutes, is typically performed under local anesthesia, and most patients experience significant visual improvement within days. Serious complications occur in fewer than 1% of cases. If surgery is recommended, the risk-benefit ratio is overwhelmingly favorable. What about pharmaceutical-grade DMSO used carefully at low concentrations? Even pharmaceutical-grade DMSO at low concentrations has no clinical evidence for cataract treatment. The safety data is reassuring. Human studies show no lenticular damage, but safety is not efficacy. The single relevant preclinical finding, Huang 2025, used injection, not drops, in a diabetic model, not age-related cataracts. If you choose to experiment, use only pharmaceutical-grade USP DMSO at concentrations no higher than 30%. Never apply it if you have any substance on your skin or eyelids that you would not want inside your eye, and continue regular ophthalmologic monitoring. But understand that you are experimenting without evidence of benefit. When will non-surgical cataract treatments become available? C-KAD is the closest candidate potentially reaching Phase 3 trials in the near future. If Phase 3 succeeds, FDA approval could follow within 3 to 5 years. The RNF114 protein degradation pathway is more promising scientifically, but is at least a decade from clinical application. I believe non-surgical options for early-stage cataracts will exist within my career, but they do not exist today. What are the early warning signs of cataracts? Gradual blurring that is not correctable with glasses, increased glare sensitivity, especially at night, fading or yellowing of colors, frequent prescription changes, and difficulty reading in low light. If you notice any of these, see an ophthalmologist for a comprehensive dilated eye exam. Early detection gives you the most options. The science of cataract treatment is at an inflection point. For the first time in medical history, we have a non-surgical candidate, C-KAD, with published placebo-controlled clinical trial data showing objective lens improvement in human eyes. We have a biological mechanism, RNF114-mediated protein degradation, that demonstrates nature has already solved cataract reversal in ground squirrels. We have a deepening understanding of the molecular pathways, oxidative stress, glycation, chaperone failure, that drive lens opacification, and evidence-based strategies to slow those pathways. What we do not have is a proven alternative to surgery for established cataracts. Not DMSO, not castor oil, not Lanosterol, not yet. My approach, and I recommend it for anyone with early-stage cataracts, is to optimize every modifiable factor while monitoring closely with objective measurements. Support your glutathione levels, control your blood glucose, protect against oxidative damage, reduce inflammation, get adequate sleep, stay physically active, and maintain regular ophthalmologic surveillance so that if surgery becomes necessary, it happens at the optimal time. I will continue to track this rapidly evolving field and update my protocols as new evidence emerges. The eyes are extraordinarily complex organs, and they deserve the same rigorous, evidence-based approach we would apply to any other aspect of our health. If this information was valuable, I encourage you to share it with anyone facing a cataract diagnosis. Informed patients make better decisions,